La Escuela de Medicina y Ciencias de la Salud se fundó en Monterrey en el año de 1978, y es ahí donde está el Centro de Innovación y Transferencia en Salud, el Hospital San José y el Hospital Zambrano Elion. En Ciudad de México se encuentra la Unidad de Investigación de Enfermedades Metabólicas del Instituto Nacional de Ciencias Médicas y Nutrición, Salvador Subirán. En la ciudad de Guadalajara, el Centro de Ciencias de la Vida. En Chihuahua, la escuela es parte de Tec Salud, integrándose también el Hospital San José, Hospital Zambrano Elion, institutos y Fundación Tec Salud, formando un centro de atención, educación e investigación. Ser la mejor escuela de medicina y ciencias de la salud de Latinoamérica es nuestra visión, enfocándonos en bienestar, prevención y longevidad. Nuestros programas académicos: médico cirujano odontólogo, licenciatura en nutrición y bienestar integral, licenciatura en psicología clínica y de la salud y licenciatura en biociencias. 17 especialidades y subespecialidades médicas, 30 cursos de alta especialidad, una maestría y 2 doctorados. Nos caracteriza nuestro modelo educativo innovador, creando una experiencia transformadora con alianzas educativas en todo el mundo, 8 grupos de investigación con enfoque estratégico y más de 50 alianzas educativas en todo el mundo. Sociedades académicas para monitorear y apoyar a los alumnos, posicionándonos dentro de los primeros 5 lugares en el examen nacional para aspirantes a residencias médicas. Nuestros programas cuentan con acreditaciones nacionales que respaldan su formación, siendo la primera escuela privada que tiene convenio con la Secretaría de Salud del Estado de Nuevo León, a través del programa multicéntrico. Y somos la única universidad privada en México que figura en el ranking QS de Medicina en Latinoamérica. Ahora que nos conoces, explora, elige, libera tu potencial transformador.
Muy buenos días, tengan todos ustedes. Soy el doctor Oscar Valencia, coordinador de este espacio de educación médica continua. Y como pueden ver, tengo aquí efectos especiales. Les pedimos que haga favor de mandar todas sus preguntas a través del chat y nos haga favor de llenar una encuesta de satisfacción al final de la sesión. Les pedimos pongan su nombre completo en la pantalla. Y en nombre de la Escuela de Medicina y Ciencias de la Salud, les doy la más cordial bienvenida a la sesión académica de pediatría. Y le voy a pedir al doctor Juan Francisco que nos haga favor de presentar a nuestro ponente.
Muchas gracias, doctor Valencia. Good morning, everyone. It's an honor and pleasure for me to introduce Dr. Jennifer Walton. She was my mentor, one of my professors during fellowship. So next slide, please, just to introduce all of her achievements that she's done throughout her career. So Dr. Walton is the current Associate Division Chief of Developmental Behavioral Pediatrics and Nationwide Children, and is an Assistant Professor of Pediatrics at Ohio State University College of Medicine. She also serves as the Director of Clinical Services at the Ohio State University Neisanger Center, which is a university center of excellence in developmental disabilities. She also holds a leadership role as a co-associate director of the Ohio State's Leadership Education in Neurodevelopmental and Related Disabilities program. Next slide. Dr. Walton specializes in identification management of children with various developmental and behavioral challenges, such as ADHD and autism spectrum disorder. She believes in promoting an interdisciplinary approach to optimizing care. So she co-directs Nationwide Children's Hospital's interdisciplinary Williams Syndrome Clinic, one of a few in the United States. Dr. Walton's interest in equity, diversity, and inclusion leads her to champion the rights of individuals with intellectual and developmental disabilities to access healthcare, education, and employment. And in July 2019, Dr. Walton became a certified implicit bias trainer. At the national level, Dr. Walton holds several important leadership positions, including a member of the Society for Developmental Behavioral Pediatrics Board of Directors. Very soon will be a member of the Executive Committee of the American Academy of Pediatrics Section on Developmental Behavioral Pediatrics. She completed her term as the chair of Pediatrics Section of the National Medical Association and previously held positions as National Vice President and past professional board member of the Student National Medical Association. Dr. Walton graduated from Northeastern Ohio University College of Medicine, her pediatrics residency at the Children's Hospital of Michigan in Detroit. Good. In addition to a fellowship in developmental behavioral pediatrics at the Children's Hospital of Philadelphia. She earned a master's in public health from the University of Pennsylvania with a focus in social and behavioral sciences. All right. So Dr. Walton, pretty much a pleasure, and I give you the floor, and we'll take care of the questions.
Thank you.
All right.
Thank you, Dr. Lozano, Dr. Francisco Lozano. I call him Juan, but it's a pleasure. It's an absolute pleasure to be invited, and I truly appreciate the invitation. And I know right now you see a blank OSU screen. You should soon, and you will soon see my slides. Excellent. You should see them now, right, Dr. Lozano? I just want to make sure they see it. Excellent.
Yes.
So this is such a unique topic. It's an absolute pleasure to talk to all of you about this topic. And it's hard because I'm not going to spend the full hour to discuss it. I want to make sure there's time for questions and answers. Because when we talk about transdisciplinary care, which I don't think we're there yet, I think we're on our way there. I think there's a few things we need to think about and consider as to why we're even having this conversation. And so I'm going to talk about a few different pieces. And then, of course, get to transdisciplinary care. But I think it comes down to what type of team do you want and for what purpose? I think that's always the piece about this. So let me go into it. So I wanted to make sure I respect the institution of who I'm presenting to. Forgive me, as I'm going to, of course, have to bring up my logos as well. And so that's where I represent. This is where I am. I'm actually live in Ohio State University's Nysanger Center. I'm in my office in the middle of an interdisciplinary clinic. They know I'm presenting to you and they say hello. And so I have no financial conflicts of interest to disclose. And so briefly, the objectives, we're actually going to review social determinants of health and actually hit on Healthy People 2030. And then you'll sort of see why. Then I'm going to illustrate disparities of care through adverse experiences. I'm going to leave it just as adverse experiences. I'm going to lay out 3 different types. Then we're going to review the history and importance of teams in healthcare. And then, of course, discuss the different types and then hit on transdisciplinary approach, which may be the most complex, but also should be essential to the future of healthcare for our individuals with intellectual and developmental disabilities. Interrupt me, of course, at any time. So when we think about Healthy People 2030, which of course comes out of the US Department of Health and Human Services, their Office of Disease and Health Promotion. And each decade they hit on healthy people and the goal of how are we going to best promote health in the best capacity. This time, for this decade, they really are heavily focusing on social determinants of health, and specifically 5 domains, which I'm laid out here. And of course, that's the graphic. And so economic stability, so that connection between financial resources people have and their health. So then if we think of social determinants, we're trying to address poverty, employment, food insecurity, housing stability. Then education access and quality. So that's the connection of education to health and well-being. Did you graduate high school? Are you enrolled in post-secondary education? What's your language and literacy level? And then early childhood education and development. Then there's healthcare access and quality, that connection between people's access to and understanding of health services and their own health. So that includes, of course, access to care, insurance coverage, health literacy. So just regular literacy and then health literacy. Then neighborhood and built environment. So that connection between where a person lives, housing, neighborhood, their built environment, and their health and well-being. So what's the quality of the housing, access to transportation, availability of healthy food, air, water quality, crime and violence. And then social and community context. So that connection between characteristics of the context within which people live, work, learn, play. So what's the cohesion within a community? What's the civic participation? Is there discrimination? Is there racism, conditions in the workplace, incarceration? So why am I bringing all of this up? Because the overall goal of Healthy People 2030 is they want to create social, physical, and economic environments that promote attaining the full potential for health and well-being of all. That's a little loaded, but that is the ultimate goal. Going back to the third domain I hit on, the domain of healthcare access and quality, that specific goal is how are we going to increase access to comprehensive, high-quality healthcare services? And then specifically, what interventions should we do worldwide to increase access to healthcare professionals and improve communication, in person or remotely? And because the goal is we want to help people get the care they need. And I think to do all this, that's going to take a team. Can't be individual. So that's one piece, right, in terms of why this is so important and why this topic is important. So then let's just take another step back and look at a lovely forest. Spring is coming. I bet it's warmer there than it is here in Ohio. I'm a little jealous. And so, but as the spring comes and you just think about nature and just the basics and foundation of even when a child is born, but then how you plant a tree. What in the environment and what does it take to really develop the course of that life to grow and really be resilient? There are, of course, protective and resilient factors we always want to make sure we maintain and sustain. And then there are other pieces within that we also have to take into account that also play a role. So in some ways, this follows social determinants of health, but now we're looking at any other adverse experiences we also need to think about. So as we think about the forest, let's think about the soil, right? But then there's adverse collective historical experiences we should think about that have come along the way that you see listed there. That's important because this is part of the framework. So soil's important, and then the roots are important, right? Which is your adverse community environment. Again, relating back to social determinants of health. So whether that's poverty, discrimination, community violence, that lack of educational, economic, or quality housing capacity. All of these are important so that way when you get that tree and then you have those leaves and branches, that child, that baby growing up, this is why we screen for adverse childhood experiences, right? All of those different ones that we know play a role, that when we're evaluating a child, we need to think about all of that as well as the protective factors. So that way we can give the best, not just diagnosis, but what recommendations can we maintain and sustain that child's life moving forward. That we cannot do alone either. That has to take a team too. Hope you all are following. I just want to give that background as to why this is important and bigger than our own specific specialties. So I just want to give some history. I am sitting in a University Center of Excellence in Developmental Disabilities, or a UCED. Didn't always used to be called that. If you think back to the 1960s, that is when really what's called University Affiliated Faculty, or UAFs, were created, and then it was advanced to University Affiliated Programs for Individuals with Developmental Disabilities, UCEDs. And these were first authorized in 1963, signed into law by JFK, president at that time, 22 days actually before he was assassinated. But that's where it came up, and actually it came up really back in the 1920s, but people realized, you know, how are we going to help care for individuals with a variety of different complex needs? That's where this sort of came from. This actually sort of started again in World War II in rehabilitation centers, and that it can't just be individual providers doing that. We have to take an interdisciplinary approach. Before that, it actually was multidisciplinary first. They said we need multiple disciplines. Then it advanced. I'm sort of giving this history of how then the laws came into being. And so it was President Kennedy's 1962 panel on, at that time they called it mental retardation. We no longer use that term, it's not politically correct. But those recommendations proclaimed the need for a continuum of care that described the selection, blending, and use in proper sequence and relationship of the medical, educational, and social services required for that individual to live at every point in their lifespan. Again, speaking to the team approach. It then moved on to 1986, President Reagan. So that's the third bullet. That specific law was signed, which is the reauthorization of early, more rigorous agenda in addressing young kids, children, and addressing their health needs with complex needs. That was the starting point to the 1994, the Individuals with Disabilities Education Act, which then got reauthorized in 2004. This is what prompts any individual which has a specific complex or special education need, this is more education-based, deserves a free and appropriate education in the least restrictive environment to have their needs met. That again requires a team approach. That also requires to look at family as part of the team. That's really important as well. And then terms multidisciplinary team came into being, and then interdisciplinary team. So when we talk about teams, and in the field of intellectual and developmental disabilities, we of course have to think of the complexity of these needs and that they require multiple professional disciplines and managing those services, addressing them over the lifespan. Patient's needs specifically also require skill and knowledge of multiple disciplines because the patient benefits from the advantages of not just independent, but interdependent practice. That's the goal. And that's been influenced, you've heard me say lifespan over and over, as well as really life course, which comes really from the maternal child health literature, that shows to be more effective in overall patients' needs and satisfaction. Then moving to the Institute of Medicine, which has brought up over the years, probably the last 20 years, in addressing unequal treatment and overall quality. So in 2001, healthcare organizations, they've stated, and under Crossing the Quality Chasm, which came out in that year, they should develop effective teams to reduce problems of lost continuity, redundancy, excess cost, and miscommunication. Then in 2003, again, speaking of quality, all healthcare professionals should be able to be educated to deliver patient-centered care as members of an interdisciplinary team. Let's move forward. The Affordable Care Act even speaks to this. How do we propose innovative approaches to education, including team management of chronic disease? We have to look at interprofessional integrated models. There's been a lot of research behind this. And are we teaching these skills and are we training providers accordingly to address that? Oh, such a good one, because that's going to be 2 slides later in terms of training, but also joint commission. And in the United States, and I bet in Mexico, they have something similar. The Joint Commission is looking at quality and safety. How are we doing things in a safe environment? And you know they come and they don't play when it comes to auditing and making sure things are safe and as they should be. And they have even spoken to long-term care patients should receive care in context of interdisciplinary teams. The World Health Organization also speaks to this as well. And so a team, right? We keep bringing up team, and we'll keep bringing it up over and over. But a team, I like this definition. It's a small number of people with complementary skills who are committed to a common purpose, performance goals, and a common approach for which they hold themselves mutually accountable. Training is a big piece. So as again, I sit not just in this Nisonga Center, but also part of the LEND Clinic. That's Leadership Education in Neurodevelopmental Disabilities. So Dr. Lozano is a former LEND trainee, as am I, as well as other faculty. And so the goal is integrated education programs. What are those? So LEND is an example of that. That's relying upon interdependent contributions of the collaborating team members. So are we including also the individual themselves with disabilities and their families and other allied professionals and community providers? AUCD stands for Association of University Centers on Disability. So they are the body where all USED programs, LEND programs come together to discuss exactly this topic and how are we better educating future providers in an interdisciplinary and really, to be honest, moving forward to transdisciplinary fashion. Hope you guys stay with me. And Dr. Lozano, you know you can interrupt me at any time. And so types of teams. So I'm going to discuss 3 types. There, you will also hear in the future, if you look at different literature, maybe more. I'm going to sort of keep it to these 3 because I think it's just the easiest, I feel, and basic way to start moving forward, and then we can advance. But I will touch on these 3 for sure: multidisciplinary, interdisciplinary, and definitely transdisciplinary. I also enjoy that, I'm going to speak to it in terms of care, clinical care, but this actually transcends to research and actually early intervention services. And one of the references and resources I use at the end that I include in a slide, and I can definitely forward, it actually applies to the early intervention approach for young children 0 to 3, early intervention services. And it's out of New Mexico. They utilize actually a transdisciplinary approach. It's actually pretty nice, and I can send you that resource. I'm actually going to stop sharing because I want to show this video. And the reason why I have this last bullet, because this video I'm going to show sort of discusses more transdisciplinary approach as it relates to research, but then overall care and how we actually look at the world. So hold tight for a second as I stop sharing. Hope you guys are with me. All right. Okay, hold tight. I'm about to share again. Screen 2, share. And then I am going to, please let me know that you can.
We need to work together to solve the problems of the world right now. All of them, and climate change is a global problem.
I am from Uruguay.
Canada.
Sou do Brasil.
Guatemala.
Michigan, USA. Ecuador.
Bogotá, Colombia.
Jamaica.
De Cuba.
Soy dominicana. Nací en Santo Domingo.
The problems humanity is facing, from climate change to natural disasters, have many, many dimensions. And so the problems are requiring us to work together to provide solutions.
Acho que o mundo enfrenta hoje vários desafios, né, no sentido de melhorar os aspectos ambientais, sociais, econômicos. Eu acho que uma das grandes mensagens que poderiam ser passadas é no sentido de abordar esses desafios de forma conjunta, de forma integrada e de forma com que as prioridades sejam atendidas, né?
We believe that doing transdisciplinary research gives us the ability to solve those problems.
So how do we do transdisciplinary work? The first thing is we sit on the same table, scientists and non-scientists. So we frame the question together, we frame the problem together, and we communicate the results together.
And in order to do that, it has to be communicated in a language that will be understood by all. And it needs to have a communication strategy that makes sure that we are not just sharing the information, but that we are actually applying the information to develop the solutions we need.
So you need a lot of different disciplines and a lot of different stakeholders to really answer that problem. That's why we need interdisciplinary teams and transdisciplinary teams.
Porque da la posibilidad de intercambiar con un grupo de científicos, de productores, de empresarios y de jóvenes talentosos de toda América, y nos ha dado la posibilidad de formular proyectos de trabajo conjunto, de abrir puertas de intercambio, de conocer nuevas experiencias, de dialogar sobre los problemas que tenemos e de proponer soluções.
Esse seminário ele é bem interessante para mim porque no meu trabalho eu trabalho exatamente com essa abordagem transdisciplinar para resolver problemas globais. Então eu tenho que todos os dias engajar com diferentes atores, diferentes setores, então a academia, terceiro setor, setor privado e também várias disciplinas.
We had the opportunity to learn from local experiences from other countries to recognize what do we have in common, what are our differences, and how we can benefit to address the issue in a regional scale.
Whenever you study a complex system, human beings being part of it, you have to realize that different groups of human beings will have different values, different culture, different ideas, and you have to try to take everything into account, and that becomes very complex. But it is important. The world is now the way it is, basically because a small group of people usually don't listen to a larger group of people. And so basically, we need, as human beings, we need to learn to listen to others. And especially as scientists, we need to realize that not everybody thinks the same way we think. And so whenever we go out to try to understand a complex situation, we need to first realize that we're going to have different voices, we're going to have different groups with different ideas, and we have to listen to all of them to be able to get a better picture of what's happening.
We need to work together to solve.
All right. Hope you guys, I sort of problems of the world right now. There we go. Okay. About to go back to my slides. So sorry. All right, here we go. I hope that sort of gives you, and I liked how they explained the importance and why globally, how important this is. So it expands beyond what we do. But I thought that was a couple things of what a couple of those speakers said. I'm sort of going to hit on into as we go into each of the different types of teams. Hold tight. And share. Hold tight. You're going to see an OSU screen. I know that. There we go. Okay, I think we're back. Okay, so we'll hit on multidisciplinary first. And so when the speaker said in terms of transdisciplinary work, we all sit at the same table. So that's not really multidisciplinary. I do want to state that that's not, that's more transdisciplinary, because multidisciplinary is where you provide services independently. So there's multiple disciplines, but they're all providing their own different services in their own ways. So there's really not a true team identity. And therefore there's decreased opportunities for communication and interaction. Therefore, not really much collaboration. There could be some, it's just decreased. Usually it utilizes a one team leader approach who's responsible for all the final decisions. This does fall more under the traditional medical model. And so if you had a visual like this, and this comes from Carol and Patel and colleagues, I like how they do their descriptions in terms of the different types of teams. The circle represents the person, and then the disciplines segment the person by their areas of expertise. The problem is there's no overlap, right? So there's not as much collaboration, but they're each doing their own separate piece. That's really the multidisciplinary model, you would say. And then if you're hungry, you know, think of a fruit salad, right? And so that's, again, if you look at all the different pieces of fruit, they can stand on their own, right? Each fruit's individual stands on their own. And they work in parallel sequentially from their discipline-specific, fruit-specific frame. If you even think about it from an early intervention standpoint, if you have children 0 to 3 and there's a child with a delay, and so professionals will provide their separate evaluations, their assessments, and then they'll set their own discipline-specific goal for the child. And then they implement their individual intervention plan. The problem is we got to come together, right? So you're right now giving a family 3 or 4 different plans. Is that really the best? How's that family get to take that? Again, there's pros and cons with each approach. There may be a need for multidisciplinary teams. I'm not taking away from that. I just want you to understand the difference with that versus now interdisciplinary approach. So that's where there's program planning, goal setting as a team, and there's more of a collective team identity of all the disciplines that are present. So services are still provided by each discipline, but there's coordination and team meetings, sometimes before, sometimes in between, sometimes after. Our roles are flexible and equal. So there's shared leadership, shared power. And then that interactive collaboration distinguishes multidisciplinary. So if you now go to another image, same circle, that circle represents the patient. Disciplines, again, are segmenting the patient by their areas of expertise, but now there's overlap between the disciplines. So that's demonstrated by the striated areas. So in the field of developmental disabilities, there's a lot of work in this area as it relates to interdisciplinary care for children and overall all families and individuals. There's a lot of research. And so for both types, communication, decision-making, it still essentially will go through the provider, the physician, who's going to coordinate, but there's more coordination here in interdisciplinary work. So forgive my bias. I know Dr. Lozano talked about the Williams Syndrome Clinic that I co-direct. This is an example of a team. So I'll give this example. It actually started here where I am sitting. It actually started at OSU through a LEND program. It came from interdisciplinary training. So Dr. Martins is the founder. She's a psychologist, major research mentor to me and Dr. Lozano, has done a lot of work in this area of Williams syndrome. And then I'm the other co-director. And the following other specialties and disciplines are all part of this clinic and live in person in the clinic. So we meet in the morning before any patient comes. We huddle in the beginning, we huddle throughout, we huddle in the middle, we huddle at the end. We have a plan. So where each discipline is going to evaluate and look at every single kid. But when it comes to the overall intervention and plan, we'll each maybe have our own recommendations, but then we'll piggyback off of each other in terms of how we want to make sure the team, when they get one summary of recommendations from all of us, these are the main areas we want you to focus on. That's collaboration. This is an example of an interdisciplinary clinic, you would say. And then again, if you're hungry, let's go to a soup, right? Or in this case, I would say maybe a chicken stew, but the goal is, and this was hard because you'll see another visual I have later in terms of food, and I was trying to figure out the best visual for food. But if you think of a chicken soup, right, other than the broth that probably brings pieces together, chicken, vegetables, they can stand on their own, right? Just like myself, the psychologist, we can stand on our own, but then there's collaboration and there's interaction. So that's why when you put us together and you season it, so then it's even better. Hope that makes sense. And forgive me for talking about food, but I feel sometimes there's different analogies to way, you look at it. So now let me bring it to early intervention. I want to try to bring it in different pieces. So remember when I said before in multidisciplinary, you have each of the different disciplines doing their evaluation on a child, and then they're setting up their own goals and recommendations. And then a family could get 4 or 5 different lists of recommendations. Freeze, you don't want that for a family. So if we think about it, there's what's called the individual family service plan. This is usually for children ages 0 to 3. If there's a delay, what happens is each specialty is going to do their evaluation, put their concerns and pieces together, but then you build the plan with the family involved and say, all right, we have identified the following developmental delay. These are the following interventions this child needs. These are the goals we're going to work on, and it's one document. It's not 4 or 5. And these are the certain goals we're going to reach where everybody has come together and agreed upon. That's an example of an interdisciplinary approach to that child with a special need who needs delays and needs intervention. I hope this is making sense. So now we're going to build to transdisciplinary. This is tough. This is complex. And even for me, I have to practice what I preach and put my bias to the side. Here's why I say this. Because involved with transdisciplinary care is the idea of role release. So this is where I have to accept. There's the acceptance that an individual team member, well, I would say this team member, me, I need to acknowledge that there could be another team member that can do as good or better a job than me in my area of expertise. That's a lot to say, right? that could be a little hard because that requires a high level of comfort and trust with cross-disciplinary training. This is not always accepted by members, physicians included. So this is hard. Not everybody is here yet. And this is going to take some work. But I think of where we need to get to go to address the history and trying to get to healthy people 2030, we need to think about this. And so services are provided by designated members, not a specific discipline. Okay, the team plans and monitors services as a unit. This is where increased communication is a must, has to happen. This is useful during limited staffing. So I think of COVID. I know we don't want to hear that anymore. I really know we don't, right? But if we think about this, when that pandemic happened, I think that should have opened our eyes. And then definitely, of course, economically, how much it hit us. Staffing is now an issue for many of our children, right? And so we don't have a lot of staff. There's shortages everywhere in terms of how are we going to provide the best services. I'm thinking about some of my own patients that tried to get early intervention. And of course, you couldn't come in person and you had to do Zoom, and that wasn't ideal. So, I mean, if we think about all the different pieces that have played into effort, this is the prime time where we can really utilize a transdisciplinary approach. This is the opportunity. And I'm going to bring it to early intervention again, but let me go into the diagram, of course. So I like this diagram because the circle is now not the patient. It is not the person. The circle is the concern or the issue, because that's what needs to be addressed by the entire team. And that begins on the basic and the center. So issue number 1, that's the first issue. That's the foundation we need to hit on. Whether we have a 4-year-old girl, there is a clear developmental delay and we're about to diagnose it, or it's global developmental delay. What are the needs of the child? What do we need to do to accomplish those needs? So transdisciplinary teams, we don't divide up the person as in the previous approaches. All of us have to communicate with each other, and the decision-making is a true joint exercise. There's technically really not one leader. So technically leader needs to go. It's a team member. So as I go back to the previous slide, it's the acceptance by an individual team member, not a leader, okay? And so that's the goal here. It involves, again, I'll repeat, acceptance by that team member that another team member can do a better job in an area of his or own expertise, that role release. So when we think of and I'm gonna sit here for a little bit on this. If we think of a transdisciplinary team, we need to think beyond our individual disciplines and work towards formulating that novel solution or perspective. It gets back to that video of how are we thinking globally and being more innovative in our work all over the world. This leads to actually development of new fields when we think of this approach. We have to view this approach as probably one of the most holistic approaches we've ever seen, where we're truly sharing skills and acquiring new skills along the way. So Dr. Lozano's probably heard this before. and maybe Dr. Lozano, you'll let me know. I believe they've already, I want to just make sure in terms of what you all have covered.
You froze on my screen just when you mentioned probably Dr. Lozano.
Yeah, okay. So no, I'm glad you said that. So no, I'm glad you said it. So Dr. Lozano, I need you to address, they have probably had previous talks on other topics. I'm assuming, right? I don't want to assume.
Yes.
So I'll use autism as a classic example. So I think, okay, perfect. So, and I believe, again, the clinical interview is very important whenever we diagnose autism spectrum disorder. There are many pieces, but you have to have the clinical interview and judgment. Many people will say ADOS, the Autism Diagnostic Observation Schedule. People say it's the gold standard, but it should not be the only standard in terms of making a diagnosis of an autism spectrum disorder. And then some specialties and providers will say that only certain providers should perform the ADOS and should be trained and performed as such, and not taken away from it. Developmental behavioral pediatricians, psychologists, yes, they are trained. But then if there's still a need and a years-long wait list of trying to get children diagnosed with autism, right now we have a clear disparity and inequity, correct? And so if that's the case, we need to then train other people and sometimes maybe train other providers, not in our discipline, to reliably be trained for the ADOS. So years ago, before even I was in attending, before Dr. Lozano was in attending, there were actually major initiatives to actually train primary care pediatricians to do the ADOS and be able to diagnose, because the reach was so huge and the demand was so big in terms of how are we going to address this concern. That's an example of coming out of my own discipline, my own self, train the next person, train the provider, so we can address and meet that issue, that need. That's an example where it was not comfortable for providers. I hope you understand that. I'm just giving one example like that. That's one piece. So that's, yeah, I would say that's one piece. Oh, I got to get to it now. Okay, so now I'm going to get to the food. And I'm a sweet tooth, so I have to go to cake. And so here's why I think of cake. And at first I had to think about this, but then it hit me. You can't take raw eggs. You can't eat that individually, right? Or flour, or the icing is sweet. You shouldn't eat that individually. But then if you put everything together and address the main concern, which is the main masterpiece, the cake, a cake is an example. This German chocolate 3-layer cake is an example of the transdisciplinary approach and the team. So you see how it's different from the other two? That's what we're talking about in terms of this is the model maybe we should think about and consider, and really coming out of ourselves, which again, I have to speak to myself and encourage myself. That's the piece in terms of how we're going to address and really reach and address these and eliminate healthcare disparities and healthcare inequities, and then specifically in pediatrics and in our children with intellectual and developmental disabilities. So I'll go back to early intervention. Back to that child, we developed that individualized family service plan, that IFSP, or if it's an older kid above the age of 3, the individualized education plan, or IEP. And so we've developed the plan. But we can't get all 5, 6, 7 disciplines out to that house or out to that school all the time to address the interventions and needs. That's when we involve another team member. It could be a teacher. It could be a specific therapist or a behavior analyst. How do we help them and we teach them? These are the main skills and goals we're trying to help address with this child. Can you help us with this process if we set up the plan? So then that team member goes to that family, comes out once or twice a week, and helps execute the plan. Representing still from the team and us, but then that team member, so not a leader, that team member helps and executes that plan. And the family's still active and involved with it. I hope that's another way to shed light on this example of transdisciplinary approach. And so when you think about all the different teams, I told you, Dr. Lozano, I'm moving. I don't have a lot of slides left because I think with this type of topic, it's about engaging the conversation. It speaks to transdisciplinary approach is important. I think it's there, and it's the next step of where we need to go. Of course, then I didn't even put up a barrier slide, though I know we're going to speak on it. How much is this going to cost? How are we going to manage the time? These are the classic barriers that are always going to come up, and they will continue to come up. And we need to address them. We need to work with and advocate and talk to insurance companies and other payers why it's so important and why that can really help their bottom line down the line. And actually we could save money if we go down this process. And so those are some things we need to think about. But I think the bigger issue is, when is a team necessary? And for specific concerns, is it necessary for real? Can a single discipline cover it? But if no, why not? Speak on that. Are the proposed disciplines available if you want to have such a team? And then which disciplines or experts are available? And then what role will each discipline play? And then how are the team members expected to work? Do we need a coordinator? And then of course, what's your data? What's your outcome? Or a few outcomes, and how are you going to measure them? So these are pieces we always have to think about. This takes work, this takes time. This, as we all know, this is not overnight. And so, but it's important and it's necessary, because we're already seeing evidence that if we really support it, really put more emphasis and understanding and back it up and invest in teams, could it be helpful down the line for everybody, and specifically for our patients and families. So I bring back one of the first slides about Healthy People 2030, right? And what is the ultimate goal? And of course, though it started in the United States, this is worldwide. How are we creating social, physical, and economic environments that promote attaining the full potential of health and well-being for all? Then specifically, healthcare access and quality. How are we going to increase access to comprehensive and high-quality health services? What interventions? We need to think outside the box. And again, this will take a team. This has to take a team. And I think in some places, it may need now a transdisciplinary team. March is Developmental Disabilities Awareness Month. It is also Women's History Month to the women. And Dr. Lozano knows I like to hit on this. So as we think about the two slides back about, is a team necessary? So then I ask you all, are there opportunities at your institution to utilize a transdisciplinary approach, right? This is just something I want us to think about. And then on top of that, where is our comfort level and our trust level? How flexible are we, right? How flexible are we in, giving or releasing our role, the role release to someone else? How is our communication with each other? Is it strong? It's got to be strong, got to work. And then I add always checking our bias. And I'm not just talking about, don't get me wrong, implicit bias is harmful. We know this, racially, gender, equity, religion, we see what's happening worldwide. I'm also going to say discipline. I think there's bias between disciplines. And maybe I'm being provocative and speaking out the box. Dr. Lozano knows I do that from time to time. But do we need to call that out? Do we need to? That's something we need to think about. Because I feel research has sort of been ahead of the game on translating research. And so if we think of a transdisciplinary clinical approach, because we're already translating research, we already made great advances and continue to, from bench to bedside, can this be another step forward in transcending healthcare? That's the goal. That's the ultimate goal, I believe. And so I thank you for your time. I told you we would go quick because I wanted to make sure I had time for questions. But I think with this type of topic, I love ongoing discussion, because how are we going to then really materialize and then get into the logistics of addressing how can we move forward with this approach? I hope this was helpful. Hope this sheds a light on the continuing work we need to do. And as we end Developmental Disabilities Awareness Month and continuing to promote and advocate for this population and the training of individuals to care for this population, we consider this and think about this approach. So I will stop sharing my screen and I will end my talk.
Well, thank you very much, Dr. Walton, for all of this. And we do have a couple of questions here.
Okay.
And so getting started, so we've talked about all of these models of just healthcare approach, but how can we integrate and coordinate that attention for a kid? I mean, these are the models. How do we get to there? I mean,
that's a loaded question. No, it's a loaded question, Juan. That's what it is. And so it's a hard question and a loaded question. And I think I've now been in this role of associate chief for a year. So I'm learning different things. I'm learning what we're doing. So we go to med school. We go to med school and our desire, we want to be a physician. We want to be a clinician. We want to take care of parents. We want to advocate. We want to take care of our kids. And then you learn along the way the behind the scenes and logistics and politics and business and billing, and you learn all those other pieces that really make, that we have to think about to make things work. I am slowly learning, and then of course I'm speaking out and advocating to the powers that be. That's why I would say earlier, it's a matter of talking to the payers. So I'll say when the Williams Syndrome Clinic came and the other interdisciplinary clinics came along, it really started from a need, from a demand, that there were a lot of families who were sick and tired of talking to their primary care clinicians over and over again, trying to describe over and over again and explain over and over again what their syndrome is. And they got a little fed up and they're like, we want these other experts. We need other people involved so we don't have to speak this over and over again. And we could say, all right, I've now found someone who understands. Now we can get to moving and understanding and doing what we need to do with my child. But when that came, and to be honest, that's how Autism Speaks and other major organizations came about. Parents spoke up, clinicians spoke up, and then they went to the powers that be and started advocating government, State House, Capitol Hill. And so when that happened, then people started talking and then other people started speaking up. And then we had to do some dirty work. We had to get on the phone for about an hour and 2 hours with insurance companies and back up and explain, this is the care and this is what we're offering. And this is what has come from it after we've seen kids for years. We are one of 8 Williams Syndrome clinics in the nation. We are probably one of only 3 that are interdisciplinary in our format, where we literally, Dr. Lozano just had a discussion last Friday, because that's when we were all together, talking about the next step in care. As to why, all right, we've now come together, we have had this conversation, we have done prior authorizations to get approval from insurance to make sure we can see the kid and address and then bill and get our estimates together. I have now have specific letters set up saying, your child's about to come to the Williams Syndrome Clinic and this is what you're going to expect. And this is the product we're going to deliver. We are going to evaluate your child. We are going to give these following recommendations. This is the diagnosis and additional findings. Because of these concerns and what that could do to that child's health over time, these are the recommendations we're doing. This took work. This took probably, for me, probably 4 years before we really got it off the ground when I got here. That's what I'm saying. This isn't quick. And of course, we're in a world where everything is quick and instant, and people need to slow that down. But Autism Speaks, Autism Care Network, similar setup. It was the same type of, there is a need. There are not a lot of providers who can address this need. The demand is real. How are we going to address that? I think the other piece that's hard to this as well is when it comes to evaluations and management of our children with intellectual and developmental disabilities, it's not black and white. Some things aren't just a blood test. And it's no offense to our other disciplines, but then it's just harder to explain. So then it's harder to tell insurance companies and other payers, this is what's really involved. My hope is, since COVID, I know we're tired of saying that term. Since COVID, mental health and behavioral health is on the rise. That's the top epidemic, really, in pediatrics. It's infectious disease and mental health. And we know those are 2 complete opposites of the spectrum. So we need to be out of the box and innovative and start addressing and telling payers, you need to cover these services. You need to cover it, or else this epidemic's going to continue. We know this, right? So that's the goal, I would say. I don't know if I answered that question because it's so loaded, but I think it's called, we have to just take time. And I'm excited for you all because I know there are leaders up in the C-suite, I would say, who understand this and are probably trying to advocate very hard for this. I strongly believe this. I know the need is very great, but I think it's time we get out of our medical field and go to the next step into the business world, start piecing together and collaborate with them on an interprofessional level. I did not mention that type of team, interprofessional level, and address that next, because we're going to need them next. And I'm sorry, I don't want to take too much time.
No, and definitely, kind of, as you said, it's a loaded question, but it's just getting into that mindset, and so I mean that's what we're doing. That's what we're working on getting into. First, interdisciplinary, just getting everyone together, and then work to a transdisciplinary model. But we're starting a Down syndrome clinic next month. Yes. Perfect. I'm so glad you are. And make sure you connect with the Down Syndrome Association nationally, and I believe it's worldwide. They're another strong group that's advocated hard. I see them.
I know. So I feel bad. So I just want to give you guys a heads up. When Dr. Lozano finished fellowship, he finished fellowship, I believe, when the beginning of the pandemic began. Right before the pandemic really started, he was supposed to be in DC with me. We were all supposed to be in Washington, DC together for the Disability Policy Seminar. The reason why I'm hitting on this hard is because, and I felt so bad, because I felt so bad for him, so I wanted him to have that experience. Even though I know you'll come to DC, we're going to make sure everybody gets to DC. And so the Disability Policy Seminar, and I bring this here is because that's the prime time where trainees, we're providers, we're self-advocates, we're family advocates, we all come together and advocate specifically on these concerns. Whether it's what is the education system like and why aren't our children receiving a free and appropriate education? Or why are we addressing civil rights, voting? There's been significant inequities in that area as well. So these are the types of pieces in interdisciplinary care we advocate for on Capitol Hill and tell our legislators. That's another piece we have to be involved, heavily involved in. I say, you know, and forgive my bias, because we're agents of change. Yes, we're to take care of patients, but we're also agents of change in other ways. And a previous mentor taught me that. And so that's another big piece we have to do. Okay, I'm sorry, go ahead, Dr. Lozano.
No. So another question was, and I think also very on point to your role, is how do we connect the pediatric teams taking care of kids and kids with complex needs and the transfer of care into the adult world?
Oh my goodness.
With that same pretty much approach of interdisciplinary care into a world that it's now probably out of our hands.
Oh, Juan.
Another loaded
You know where I sit.
You know
where I sit. You know where I sit. And so, that's a fabulous question. Whoever has a fabulous question, number one, you are 100% right, number two. That is the next barrier and hurdle we need to hit. There are certain institutions. I am sitting in one who gets that and is starting that process. And so that's trying to address transition, because that's the big piece you're hitting on, is transition to adult care for our individuals with intellectual and developmental disabilities. There are different, I'm gonna try to figure out the best way to organize my answer to your question. There are national initiatives. They have actually come out of the Maternal Child Health Bureau, which is with HRSA now. There's also a thing called GOT Transition. Want to make sure they have information on GOT Transition. They have different templates on what to ask and how to help families, guide them through that process. But then we also have been working with internal medicine pediatrics providers, as well as certain family medicine providers. And we're trying to also reach more other internal medicine providers, but this actually starts really back to medical school training. How do we address the importance of that need in that group of people in that gap? So now I'll show my bias. I'm at an institution where OSU has what's called a transition program. It's called the Center for Autism Services and Transition. So they specifically have one for CAST. They are bringing back, rejuvenating also what's called CAPS. So for those individuals who don't have autism, but also have another intellectual or developmental disability, if you turn 16 or 17 years, you can be eligible to then transition and see a provider that's actually internal medicine peds, so understands the peds world and the adult world. But that program, this clinic, it's affiliated with Ohio State, is not just the provider only. They have social workers, they have parent advocates, they have different mentors, and now, Juan, I'm sorry because you just left, they now have a psychiatrist. She actually sits right here. She's not here right now, she's seeing a patient, but she actually comes into that program weekly. And so she's trying to address the mental health concerns as well as the physical concerns. And they see these patients through age 24. So we're actually getting into the adult where actual transition is taking place. Because the goal is we want to make sure we equip that individual to understand, all right, so when I walk in, will you be able to answer the nurse's questions about your own allergies, your own medications? Do you know where your pharmacy is located? Do you have your insurance information? Can you sign consent? So that's a specific piece, but that's a process. And to be honest, that process should start actually before the child enters high school. So technically our rule federally here, age 14 years, you should start asking and having the conversation. one of our colleagues, Dr. Lozano and I, it's Dr. Bartram, Dr. Lozano, she's continuing her QI, a quality improvement project on transition, because it's our job, we are to introduce this process. And so, and actually have the questions and have ongoing conversations. So by the time they turn 17, 18, the parent's not crying to me saying, I don't want to leave, because that's what happens. Parents are crying to us saying we don't want to leave. And then some of us still have patients in our 20s. So we gotta fix that. That's not, we're worsening the disparity if we don't start early. So we need to start the process early. I highly recommend looking at GOT Transition, because they do have specific and nice documents and templates to how to ask those questions. It's a great website, but also I think it's still a website, but I know they have a lot of work. The American Academy of Pediatrics, I sit on another expert group that's exactly looking at this as well, because we're trying to enhance it and be culturally responsive with it as well, because that can be tough also. But that's a big piece. It's another loaded question, but it starts early. So 14 years, actually in school and education, part of the rule for individualized education plans, when you turn 14, they're supposed to have a transition goal in the plan. So that's supposed to happen. So I highly recommend make sure they look at that. And forgive me for not knowing your rules and your customs, but I want to make sure they look at something similar like that, because that would be really great.
I think the mindset should be on that age range, even though rules might be different. But just starting the conversation, checking on all of their needs, and for our kids with developmental disabilities, I mean, what our goals are transforming into, or more probably adaptive and behavioral stuff than other concerns or issues that could be going on. So I think one probably final question is, so with all of these models, and you being part of different models to your career, what can you say about the economic impact? So I know you were talking about that piece at some point, but I mean, just telling leadership, telling insurance, telling families that, you know, this model actually can save money, can have a bigger impact, not just on the family's pocket, on the healthcare system's pocket, on the, I don't know, the government's pocket. So, I mean, what has been your experience with that?
So what's been my experience? This is so interesting. I love how you asked 3 loaded questions. Thanks. No, it's great. It's great. And so I would say, and for those, and forgive me only because I don't know your rules. So one is your institution, is it an academic institution, community-based, like mix? I'm just trying to, there's a reason why I'm asking this question. There's a reason why.
Yes, so we are academic, but the vast majority are private practice within an academic institution or on their own. Okay,
which means then if you go up the rank, do you have, in terms of, well, I don't need to go down that path. I'll answer it this way. I'm gonna answer it this way. This is how I feel. I actually almost cried twice this week because 2 parents called in or sent, my chart messages and said, we just want to let you know, Dr. Paul, you've been killing it, and our child asked for you. When they showed up in the urgent care, they were looking, where's Dr. Walton? We knew you weren't there. But it was about, the compliments were more around, we appreciate the care you're doing because we know it's making a difference whenever we go to these other places, because other providers realize, I need to change my approach when this patient and family comes into the room, because I want to make sure I address their needs right. And they could tell us the difference is starting. I can also say when it comes to these, I'm going to take a step back and pivot. When I see our patients in Williams Syndrome Clinic, for example, it's not that I'm seeing them all the time, right? So these visits, though, if you look at the dollar amounts, I was able to look at the dollar amount and see the amount that can happen on an evaluation, and it can be pricey, I'm not going to lie, but it's not that we're paying this once a month for this family. No, as you know, my kids only really need to be seen once a year after they turn 3, or once every 6 months. So if we think about it from a cost standpoint, It's not that much in the year if you think about the whole year. Because the important piece is you take this back, I finish my note and I send it to the primary care provider to let them know these are the things I have done and ordered and want recommended through the year. And this is what we're going to continue to follow and watch for. So that way everybody knows and everybody's still on the same page. Now there's different certain therapies that to be honest, we're still going to happen no matter what, whether they saw me. We still need speech therapy. It's clearly in the school. It's clearly an outpatient, as well as OT and PT. Music therapy is coming up as well. But the goal is we shouldn't have to see these kids once a month all the time. So if we think about it from that type of money standpoint, that already saves money, number one. Number two, I would also say, then it's patient satisfaction. That's the other piece. To the point where there weren't 8 clinics for Williams syndrome. It was back to 5 before that. And now, to be honest, sneak peek, there's a goal they're trying to get another 2. Because I think people are realizing the growth and the importance of we need to make sure more clinics like this exist. There's a certain region of the United States, there is no Williams syndrome clinic, like not even close, not represented. And it's sort of sad because I know there's a lot of families in that region that need it. And so we need a clinic there. So, because it's oversaturated in other clinics, because that's my next concern in inequity right there, that they have to travel across the country. But that's how I can tell we're going to make steps because the demand's there and they're starting to open more clinics. If you think back, Down syndrome, my gosh, before we were even thought of what Down syndrome clinics exist. And now that's the most popular and probably the most populated one going everywhere because everyone knows the need and what those individuals truly need and how they're living longer. That's the other piece too. So it shows there's evidence there as well. So sometimes naturally that evidence occurs, sometimes patients and making sure those families get feedback, that's important too. As we all know in the world of advocacy, when you go to government, the best way, unfortunately, to sway legislators is hearing personal testimonies. And so when certain families show up and say, this is what happened, and this is why I don't see them anymore, and this is why I see them, that makes a difference. It makes a big difference. Worldwide, there are still, though it still may be rare, there's a pretty nice sized population of individuals with developmental disabilities, and their voice needs to be heard, right? And so it's 1 in 44 for autism spectrum disorder. There is a good amount of people in the world who have a diagnosis, and they need their needs need to be met, period. And so it's our responsibility to meet their needs. Wow, we went exactly to the hour. I'm so sorry. Like we really did it. I'm so sorry, y'all.
It was great. It was great. No, thank you very much, Jen, for Dr. Walton, for your time. It was just amazing just hearing all of this and your experiences, your approach. So again, thank you. And Dr. Valencia.
Muchas gracias, Doctora Jennifer Walton. Thank you very much. It was wonderful to hear you. Thank you for sharing your knowledge and your experience with us. It was really an honor to hear you. We hope to see you again very soon in our institution.
I need to get there. Juan and I, we've been thinking about it.
We're going to be.
Pandemic was the reason why we didn't come.
Exactly. It's been an absolute honor, you guys. Thank you so much. I appreciate this so much.
Thank you very much. Y no olviden llenar la encuesta de satisfacción. Y los esperamos la próxima semana con un tema muy interesante que va a ser más herramientas para el consultorio que el doctor Felicitos Leal nos va a impartir la próxima semana. Muchas gracias a todos. Thank you, Dr. Walton, doctor Juan Francisco Lozano. Muchas gracias a toda nuestra audiencia.
All right, Jen.
All right.
Thank you. Thank you. It was nice seeing you.
Nice seeing you too, of course. Tell the whole family I said hey.
Sure.
Tell your father.
Everyone's
I think I saw him
there.
come on there too. Tell him I said hey.
Oh, there he is. Probably around. Yes.
Yes.
All right, Jen. Say hi to everyone.
Will do. Have a good one, you guys.
Bye.